The topic of discussion that we are going to deal right now is we're going to talk about esophageal tumor. Right now, the series that will follow is we'll initially look toward all these things, all these contents, these diagrams. We'll be clear about all these things. We'll be having recap through the content of first aid, and then what we'll do is we'll just move toward the content of our Robbins, and then what will correlate the things that we have studied with the diagram and content written right here. Okay, now without delay, let's move toward our topic. Okay, so now the first thing that comes in our mind whenever we are talking about tumor is the thing is that there are two types of tumor, that is benign and another is malignant, right? Okay. Now here, talking about the benign tumor of esophagus, the most common benign tumor of esophagus is our leiomyoma. Right, leiomyoma. And what is this leiomyoma? It is the benign tumor that has smooth muscle origin, right? And in detail, what we are going to deal right now is we are going to talk about the malignant tumor of esophagus, and the malignant tumor that we are going to talk about is we are going to talk about adenocarcinoma, and another is we are going to talk about what? We are going to talk about squamous cell carcinoma. Squamous cell carcinoma. Right now. Okay, now without delay, let's move toward its type. Okay, we have already mentioned what? We have already mentioned about leiomyoma. It is the most common benign esophageal tumor. And talking about the malignant tumors, we have squamous cell carcinoma and adenocarcinoma. Now, what are the difference between these two? Right, the squamous cell carcinoma, right, it is the most common carcinoma worldwide, right? The most common carcinoma worldwide present is our squamous cell carcinoma. While talking about adenocarcinoma, it is the carcinoma that is more prevalent in Western countries, that is our such as America, right? America, or we can say US. So from A we can memorize it. Okay, now another difference is that squamous cell carcinoma affects middle 1/3 of esophagus. Okay, I'd like to draw here our what? Okay, this is our esophagus, right? This is our esophagus. This is our what? This is our stomach, right? This is our stomach. So, talking about the position of our what? Talking about the position of our this squamous cell carcinoma, it affects middle 1/3, right? Here middle 1/3 is affected by our what? It is affected by our squamous cell carcinoma, right? And while talking the lower one is affected by our what? This will be affected by our adenocarcinoma. Okay, if you remember, or if you have gone through our previous lecture about Ecclesia, Cardia, Barrett esophagus, at that time you will find that Ecclesia, Cardia, if you just recall the fact, then you will find that Barrett esophagus, right? Barrett esophagus. Okay, we're talking about Barrett esophagus. Barrett esophagus was what? A risk factor for causing adenocarcinoma, right? Now, okay, Barrett esophagus, it was also affecting what? Lower 1/3 area of esophagus, or the area that contains lower esophageal sphincter, right? Similarly, if you remember the lecture on Ecclesia, Cardia, then you will find that Ecclesia, Cardia was the risk factor for causing squamous cell carcinoma, right? Okay, but the Ecclesia, Cardia was also affecting the lower 1/3 of our esophagus. That thing will get clear now somewhat later on. So the thing that I would like to make clear, that I wanted to make clear right through this point, is that it affects middle 1/3 of esophagus. It is about squamous cell carcinoma here, whereas the adenocarcinoma, it affects the lower 1/3 of esophagus, which is right here. Now moving toward other points, right? Other points about these things, I'd like to take you toward what? The specific topic of squamous cell carcinoma. Right, now we're talking about specifically about squamous cell carcinoma, right? We're talking specifically about squamous cell carcinoma, talking about its risk factor. The thing that we need to keep in our mind is, right, the main risk factor are smoking and alcohol, right? Now what does smoking and alcohol do? They cause irritation on squamous lining. They will do irritation, right? They will do irritation on squamous lining, right? Lining of esophagus. Okay, and these irritation, what they will do is they can give rise to dysplasia, dysplasia, and finally this dysplasia can lead to cancer, eventually can lead to cancer. So this is easy. Now another important risk factor is, which is of high yield one, and that is intake of nitrosomine. Right, now what are these nitrosomine? These are the chemical that are used to produce smoked food, right, smoked food or grilled food. Okay, now these nitrosomine are also used in the case of these are also used as food preservative. So the food that is preserved for a long time, it contains nitrosomines, and these food are to be avoided because they can cause squamous cell carcinoma. Right, another risk factor is intake of hot drinks such as hot tea, hot coffee, extremely hot tea and hot coffee, that may also cause squamous cell carcinoma. And similarly, chronic Ecclesia cardia. Yes, I have mentioned sometime earlier that Ecclesia cardia. What is this Ecclesia cardia? Ecclesia cardia is the condition in which what will happen, in which the lower part of esophagus will not it will not do, it will not dilate. Right, it will not, the lower part of esophagus, lower or the region of lower esophageal sphincter will not dilate. Right, will not dilate. As it will not dilate, what will happen, there will be the constriction and food particle will not be right, there will be constriction, there will be no passage of food particle through it, because of which there will be accumulation of food particle, and these food particle on long standing in these esophagus will produce toxic substance. Right, they may affect or they may cause irritation on the region of on the region of our on the region of esophageal mucosa. So chronic Ecclesia cardia is also a risk factor for our squamous cell carcinoma. Right, squamous cell carcinoma. Okay, now moving forward, what we have is, okay, one important point that I would like to mention right here, and that is, we are talking about as we have already mentioned that squamous cell carcinoma, it affects it affects middle one third. Right, middle one third of esophagus. But this Ecclesia cardia, it is involved in lower one third of esophagus. Right, lower one third of esophagus. Now, okay, that means it did not go parallel with squamous cell carcinoma. Okay, we can say that these our Ecclesia cardia, it is exception in the case of location, right, which we are studying under the topic of squamous cell carcinoma. Okay, that means the carcinoma that is not confined to middle one third is Ecclesia cardia due to Ecclesia cardia. Right, okay, whenever there will be the question, right, and the question will be like this: lower esophageal cancer, which is Adenocarcinoma. Right, lower esophageal cancer. Okay, lower esophageal cancer, which is Adenocarcinoma, is due to what? It is due to our Barrett esophagus. Right, lower esophageal cancer, right, that is Adenocarcinoma is due to Barrett esophagus. But if there will be the question, that will be lower esophageal cancer, right, lower esophageal cancer, which is squamous cell carcinoma, is due to, at that time we have to choose chronic Ecclesia cardia. So that is the important point that we need to keep in our mind right here. Okay, now moving further, what we have is, we have, okay, the portion, right, we have Plumber vision syndrome. Now this Plumber vision syndrome is also risk factor for squamous cell carcinoma. Now what is this Plumber vision syndrome? Okay, now middle-aged female, right, it is seen in middle-aged female, right. Here what will happen is, there will be the low wave located in upper one third region. Okay, what is this? This is our esophagus. Right, this is our esophagus. Now what will happen in this upper one third, there will be the wave, presence of wave. Right, presence of wave. As there will be the presence of wave, what is a wave? Simply it is our wave is simply, what is this wave? It is mucosal protrusion. Let's say it is our it is mucosal protrusion. Right, as there will be the mucosal protrusion, the food material that is present in this area will not pass easily to its lower region. Right, and this will cause a lot of obstruction right here. Now as I said that it is seen in middle-aged female, right, and what will happen in this condition is, there will be a wave located in upper one third region. right? Upper 1/3 region. Now it will be presented by what? It will be presented by iron deficiency anemia, as the what, the food content will not reach into stomach and there will be no absorption of iron, right? Similarly, what will happen? Atrophic glossitis will occur. Atrophic glossitis, what is this? It is what? Atrophy of oral mucosal cavity, right? Atrophy of oral mucosal cavity, especially in tongue region, right? Because of which a red beefy tongue will appear. So these are what? These are the triad, right? These are the triad of Plumber vision syndrome. Plumber vision syndrome will, when Plumber syndrome will take place, there will be what? Iron deficiency anemia, atrophic glossitis, and there will be esophageal wave, right? Presence of esophageal wave, and it is mainly seen in middle-aged female, and there is the wave located in 1/3, upper 1/3 of what? Our esophagus. Now here another one important thing that I would like to mention here is about another one important thing that I would like to mention here is it is about tylosis et palmaris, right? What is this tylosis et palmaris? It is simply what? Thickening. Tylosis means thickening, right? Thickening. Now thickening at what? Palmar region. Now what is this palmar region? It is our what? It is our, you can see right here, foot. It is our what? And the palm, our hand region, right? Okay, now tylosis et palmaris. Now here what is going on here is, right, there will be congenital thickening, right? There will be congenital thickening, congenital hyperkeratosis. What I'm saying? Hyperkeratosis, right? Hyperkeratosis. That means there is deposition of a lot of keratin, and this deposition of a lot of keratin that is eventually causing thickening palm and soles. It is also a risk factor for squamous cell carcinoma. Okay, now another thing that I would like to mention here is, okay, there is ingestion of locally made alcohol. Okay, now in the case of locally made alcohol, right, this locally made alcohol is our Merck silk, right? MURSIK, Merck silk. It is what? It is locally made alcohol. Now when consuming this locally made alcohol that is containing Merck silk, right, at that time there will be the appearance of squamous cell carcinoma in very young age. That means a 30-year-old person is visiting you, and he is what? He is consuming a lot of Merck silk, right? That is locally made alcohol. That means that 30-year-old patient is more likely to suffer from what? Squamous cell carcinoma. So that is one important thing. That is also okay. Consuming of Merck silk is also a risk factor for our what? Squamous cell carcinoma. And another thing that I would like to mention is, okay, here you can see, here it is talking about wave that is present in upper 1/3 region. Food pantry is not able to pass properly, and here this esophageal wave, it is a feature of what? Plumber Vinson syndrome, right? Okay, now this is about what? This is about squamous cell carcinoma. Okay, now talking microscopically, right? Microscopically, what we'll see is there will be deposition of keratins, right? Talking microscopically, what we'll see is there will be deposition of keratins. Okay. Now here, as you can see, these appear as what? These appear as what? These appear as the collection of nest of what? Nest of tumor cell, right? These appear as nest cells, right? Collection of tumor cells, nest cells, right? Collection of tumor cells or nest cells. Now these what they will do is they will produce keratin. Now these keratin will be appear as keratin pearls. Okay, now what we are looking at the squamous cell carcinoma, histology of squamous cell carcinoma. Here what is going on is there is collection of what? Collection of nest like cells, right? Tumor cells which produce what? Keratin, and these keratin will appear as keratin pearls, right? Keratin pulps. Okay, now we're looking toward what? Immunohistochemical marker. We'll find what? Cytokeratin CK, right? We'll use cytokeratin CK to visualize these things. Now, okay, now this was what? This was about squamous cell carcinoma, right? Now let's move toward another thing, important thing, that is adenocarcinoma. If you remember adenocarcinoma, if you recall the lecture on Barrett esophagus, at the time we were saying that Barrett esophagus is what risk factor for adenocarcinoma. And as we have already studied what is Barrett esophagus. Barrett esophagus is a condition. It is chronic GERD or chronic reflux esophagitis, right? Chronic reflux esophagitis. What will happen in this condition? In this condition there will be the replacement of stratified squamous epithelium, right, with what? Intestinal columnar cells. Now we are saying, why we are saying intestinal columnar cell? Because here there will be the presence of goblet cells, right? Goblet cells. Okay, goblet cells. Now what is going on? Why this happens? Because of what? Because of efflux of gastric contents, right? Because of efflux of gastric contents. The main region where the main region that we will find, in which we will find Barrett esophagus, is our lower 1/3 of esophagus, or the region where there will be the presence of what? Lower esophageal sphincter, right? So we said that if there will be the chronic damage to esophagus because of Barrett esophagus, because of what? Barrett esophagus, then there can be the condition of adenocarcinoma also, right? So these are the things that we discussed. Okay. Now moving further, what we have is, we have talking about what risk factor, right? About adenocarcinoma, what we will find is mainly, right, in the case of adenocarcinoma, right, we already discussed that this is more prevalent in Western countries as in America. So these are mainly found in white peoples, right, white peoples. Now why this occurs? This occurs because of long standing GERD, gastroesophageal reflux disease, and that is what Barrett esophagus is. Now another thing is, right, yes, it is the risk factor for this is also smoking, right? Smoking and alcohol. As we have already mentioned that this smoking and alcohol, what they will do, they will just what they will do, they will cause irritation in our esophagus, and this irritation can cause dysplasia, and finally that can result in cancer. Now similarly, talking about other thing, right, it can be also because of obesity, right? It can be also because of obesity, radiation. And one important thing that I would like to mention here is about the role of H. pylori. Okay, it is clearly written in Robbins, right, about H. pylori. Now what H. pylori does is, right, H. pylori causes gastric atrophy, right? What I'm saying is H. pylori, okay, let me write here somewhere, right here. H. pylori, what it does is it causes gastric atrophy, right? Gastric atrophy means decrease in HCl secretion. If there will be decrease in HCl secretion, then obviously this means there will be what? There will be less chance of what? Barrett esophagus. Why less chance of Barrett esophagus? Because of what? Reflux of this acid into esophagus, there was what? There was the condition called Barrett esophagus, right? Now what will happen is, if there will be less production of HCl, then obviously the condition of Barrett esophagus will be decreased, simply, right? So here what we can see is, the H. pylori, it increases the chances of adenocarcinoma in stomach, right? But here what we are finding right now is, it protects or it prevents the adenocarcinoma of stomach. Of esophagus. That means it will inhibit the adenocarcinoma of esophagus because it is causing gastric atrophy. But here, since it is causing gastric atrophy, it will enhance adenocarcinoma of stomach. So this is one important important concept that we need to get. Okay, now since we are talking about what we are talking about, our adenocarcinoma, right? Okay, now talking about the clinical feature of adenocarcinoma, right? There will be progressive dysphagia. Dysphagia is difficulty in swallowing, right? Difficulty in swallowing to solid and then to liquid, right? Solid food are difficult to swallow than liquid food in the case of cancer, but this goes opposite in the case of what? Ecclesia cardia. If you remember our lecture on Ecclesia Cardia, we talked that the liquid are more difficult to swallow than solid in the case of Ecclesia Cardia, but this goes opposite in the case of cancer, right? In the case of cancer. So now if there will be difficulty in swallowing, obviously the person will consume less amount of food and there will be weight loss, right? Chest pain, right? And there will be the involvement of our what? Laryngeal nerve also. And because of laryngeal nerve involvement, right, there will be hoarsening of voice, right? Hoarsening of voice. There will be cough, right? Because of cough, in this cough there can be tracheal involvement also. Now okay, this is what we have studied till now, right? We talked about these things. Now let us move toward, right, move toward what? The histology of adenocarcinoma. If you'll see the histology of adenocarcinoma, what you will find is, right, adenocarcinoma, what you will find is there will be glandular formation, right? What are these? These are glandular formation, right? These are glandular formation. But these glandular formation are because of what? Because of abnormal what? These are because of what? Because of abnormal our tumor cells. These glandular formations are because of abnormal tumor cells, and that is why they are lined by our what? Malignant or abnormal tumor cells. Glands are lined by malignant cells, right? Okay, now here abnormal or malignant cells means what? The one having high NC ratio, the one with hyper chromatic nucleus, these and that things, right? Okay, this is about what? This is about the microscopic of adenocarcinoma. Now how we will diagnose, right? How we will diagnose if the particular malignancy is squamous cell carcinoma or our adenocarcinoma. So to diagnose that, what we'll do is we'll do endoscopy, right? Initially we'll do endoscopy, right? Okay, now while doing endoscopy, we know that there are 4 anatomical constriction, right? Anatomical narrowing or anatomical constriction normally in our body, right? In the region of esophagus, right? In the region of esophagus there are 4 anatomical narrowing, as we have discussed in clinical applied esophagus, right? Now out of that 4 constriction or 4 narrowing, if we will find further more narrowing, then we'll just confirm that now here is the condition of malignancy or here is the condition of esophageal tumor. Now okay, now after finding more constriction or narrowing, what we'll do is we'll do biopsy. Now okay, now on doing biopsy, what we'll see is if in that biopsy we'll find goblet cell, then obviously there will be, and this will be the case of adenocarcinoma, right? But if we'll not see goblet cell, we'll see keratin, right? If we'll see keratin filled squamous cells, then we'll say that condition as squamous cell carcinoma. That's all. Now while doing radiological examination, right? Radiological examination, we will tell patient to swallow barium. Now while swallowing that barium, what we'll find is we'll find a rat tail appearance. Okay, now why this rat tail appearance? Okay, now we know that in the case of malignancy, right, in the case of what? In the case of our this esophageal carcinoma, we are saying that there will be narrowing of lumen, right? There will be narrowing of lumen, right? There will be narrowing of lumen, but this narrowing of lumen will be what? It will be irregular narrowing of lumen. It will be irregular narrowing of lumen of esophagus. As there will be irregular narrowing, this will appear as what? This will appear as a rat tail appearance. It will be called a rat tail appearance, and this rat tail appearance is the finding of our esophageal what? Carcinoma. Now I would like to take you toward the previous lecture content, right, in which we were talking about what? We're talking about broad beak appearance. Now what was this broad beak appearance? This broad beak appearance was seen in Ecclesia Cardia, right, in which there was smooth muscle narrowing, right? Has what? It has this broad beak appearance has regular, right? Regular what? Regular narrowing of smooth muscle. Narrowing of smooth muscle. Okay, smooth muscle. Now this is the diagnostic characteristics in which we will be able to diagnose, we will able to differentiate what? Our Ecclesia Cardia and our what? Our esophageal cancer. So if there will be regular narrowing of smooth muscle, then that condition will be what, and that will be what, broad beak appearance, and that is mainly seen in the case of what, in the case of Ecclesia cardia. But if there will be rat tail appearance, right, irregular narrowing of lumen of esophagus, then that will be what, that will be the condition of esophageal tumor, right? Okay, now since we are talking about what, we are talking about cancers, there would be obviously the spread of cancers also, right? Now spread of esophageal carcinoma, right? Spread of esophageal carcinoma, it causes the involvement of what, it causes the involvement of liver, right? And if there is the involvement of upper one third, then there the most common site for spread is our cervical lymph node. If there will be what, middle one third involvement, then there will be what, the mediastinal lymph node involvement will be maximum. Similarly, lower one third, what will happen in the case of lower one third, there will be cardiac or gastric lymph node involvement. So this is about what, this is about spread of what, our esophageal cancer. Okay, we discussed about this topic also. Now what we are going to do is, now okay, now I would like to talk about something about what, genetic mutation. Since these are what, these are the condition of cancer, right? These are the cancer cells, right? Cancer cells. So obviously there would be gene mutation within these cells also. So in the case of squamous cell cancer, squamous cell cancer, what will happen is, there will be what, there will be amplification in SOX2, right? SOX2 gene, right? SOX2 gene, so we can memorize it as SS, right? SOX2 gene will be amplified in the case of what, our squamous cell carcinoma. Now if you recall the lecture on hematology, right? Okay, in the case of mantle cell carcinoma, what was going on there is, there was the amplification of SOX11, right? SOX11 gene. So that is one important correlation. Okay, now what will happen to other things such as cyclin D, right? There will be the overactivity of our what, cyclin D. Similarly, talking about our what, tumor suppressor genes such as P53, right? NOTCS, notch, right? These tumor suppressor gene, they will reduce their activity, or there will be the underactivity of our tumor suppressor gene. Now talking about what, now talking about adenocarcinoma, right? Talking about adenocarcinoma, the thing that we need to know here is, earlierly there will be the involvement of P53 mutation, right? But later on, as the condition advances, there will be the involvement of cyclin D, right, and cyclin E. Cyclin D and E, there will be the involvement of cyclin D and cyclin E. Okay, this was about what, this was about genetic mutation in esophageal cancer, right? Genetic mutation in esophageal cancer. Now let us move toward the content of first aid. Right here it is less, but it is high yield esophageal cancer, right? It is presented with progressive dysplasia, first solid, then liquid. Okay, dysphagia. Okay, as we have said, dysphagia in the case of cancer, here there will be the difficulty of swallowing of solids, right? But in the case of what, Ecclesia cardia, we said that there will be difficulty in swallowing liquid higher than our solid, right? Solid. Here we are talking about gravity, right? If you are not able to recall, please go and watch that lecture also. And because of this, there will be the weight loss, aggressive course due to lack of serosa in esophageal wall, allowing rapid extension, right? Okay. Poor prognosis due to advanced disease at presentation. Okay, now here two type of malignancy, right? One is squamous cell carcinoma, another is adenocarcinoma. Yes, we discussed about squamous cell carcinoma. It involves upper 2-3 region. Risk factors are alcohol, hot drink, caustic stricture, smoking, Ecclesia cardia, right? Similarly, it is most prevalent in worldwide, right? Worldwidely it is most prevalent. Talking about adenocarcinoma, it involves lower 1-3 region, right? The risk factor are chronic gastric esophageal reflux disease, Barrett esophagus, obesity, tobacco and smoking. And it is more prevalent where? It is more prevalent in America, right? In Western countries. So this was about what? This was about esophageal tumor, our description. Now let us move toward what? Let us move toward the content of our what? Robbins. Now here we're talking about the content of Robbins, yes, esophageal tumor, right? Esophageal tumor. Okay, the thing that is written here is, here it is talking about adenocarcinoma, the prevalence of adenocarcinoma in United States, right? Here the esophageal tumor, that can be what, the esophageal tumor can be what, benign also, and that is leiomyoma, right? And malignant, and under malignant we will study about squamous cell carcinoma and adenocarcinoma. In adenocarcinoma, what we said, that the main cause of adenocarcinoma is Barrett esophagus and long standing GERDs. We talked about Helicobacter pylori, how it is what, it is protecting what, adenocarcinoma of it is preventing adenocarcinoma of what, adenocarcinoma of our esophagus, but it is enhancing adenocarcinoma of stomach, right? It is, the thing is written right here, it is saying that adenocarcinoma is more common in men, right? It is talking about the country where it is more prevalent and the country where it is less prevalent, right? Talking about pathogenicity, same thing, Barrett esophagus will cause adenocarcinoma, right? Okay, if there will be the extended like this, and here it is written the molecular mechanism that we did not go through, right? We just talked about what, we talked about cyclin E, cyclin D, right? They were what, they were involved in the late phase, and we mentioned that what, P53, right? P53 was detected in early phase, it was involved in early phase. Yes, we talked about these things. Moving further, yes, you can see what is this, this is our adenocarcinoma, and this is what, this is our squamous cell carcinoma, because here you can see it, the involvement of what is involved right here, mid esophagus is involved right here, but here what is involved here, our lower what, lower esophagus is involved here, that is close to gastric content. So right, so we can say that it involves gastric cardia also. Talking about morphology, right? Talking about morphology, what we are saying is that, okay, we did not talk much about morphology, and microscopically we talked about microscopic structure, in which what, there were a lot of glands, right? Glands, they were covered by malignant what, there were a lot of glands, they were covered by what, they were covered by malignant or tumor cells, right? Okay, and talking about clinical features, we said that, right, we already said there will be weight loss. Okay, we said that there will be the problem in swallowing, chest pain, vomiting. Okay, and this was what, this was about adenocarcinoma. Similarly, we talked about squamous cell carcinoma, it is more prevalent outside the US, right, not within US. Okay, and we talked about what, risk factor, alcohol, tobacco. We talked about Plumber vision syndrome, the triad of Plumber vision syndrome, we talked things. Okay, and this was all about what. Okay, now here in these diagrams, right, in diagram A, what we can see is, it is esophageal adenocarcinoma organized in back-to-back glands, right? In the case of adenocarcinoma, what you will see the glands that are being covered by what, malignant cells, right? Glands are being covered by malignant cell. Okay, now this malignant cell means what, high NC ratio, our what, hyperchromatic nucleus, like that. And similarly in figure number 2, you can see squamous cell carcinoma. Here you, what you will see, squamous cell carcinoma, right? There are bird nest like appearance of what, the tumor cells that consist of what, keratin poles, right? Okay, now this was all about what, this was all about adenocarcinoma. And here in adenocarcinoma we talked about what, SOX2 gene, right? That was what, that was amplifying, right? Similarly, we talked there will be the loss in function of tumor suppression genes, these and that thing. So this was all about what, this was all about our what, esophageal tumor. So this much for the discussion. Now okay, we are talking about what, we were talking about esophageal tumor. So this much for the discussion. Hope you get it. Thank you and have a great time.